All right. Looks like I'm live. I'm going to burn a few more seconds here so we can jump a couple of people on. Have a couple of people jump on. And then I'm going to tell a story about how this presentation that I've got came to be. So let me see if I can. There we go. See, all right. So here's the deal. If I share my entire screen, I can't see you. I can't see that you're asking questions. However, if I keep it like this, then I can go through this PowerPoint and share it with you. But there is a story behind what I want to share with you today. We're going to talk about the fourth generation of regenerative product, these things called stem cell exosomes. The story goes, and the reason why I wrote this particular presentation is this. I went to Boise last week, and Boise is 4 hours from my office or 4.5 hours from my home. And one of the exosome companies that we've used was putting on a presentation. So anytime I go to these seminars or conferences or try to grab little chunks of knowledge here and there, I always get something out of it. I always get some sort of clinical gem that changes a lot for me. So I try to get as much of those as I can. And this particular one was a dinner in Boise. And I'm not going to name any names or point out any companies or anything like that because, well, frankly, the presentation, the dinner was good. I mean, it was free dinner that I had to drive 4 hours for. But no, the presentation had really good content, but the delivery kind of stunk. There was a couple reasons for that. Number one, I thought the presenter was actually going to be there in person, which he was not. And number two, the AV that they had set up for this presentation was awful. They were trying to run it through into a group of about 10 people in a small room in a very busy restaurant. So they're trying to run it off of just like $10 speakers off of a laptop you couldn't hear. And there was a gigantic disconnect. And the disconnect comes because you have people that are very, very smart on the laboratory side, as in the science side of what is behind this product and what is the science, what's the research, and what are the little intricate details. There's a disconnect between them and the guys like me that are on the clinical side of it, is like, how do we apply this to patients? So you have these ladies and these men that are changing the absolute world of healthcare. But when they get in there and they start talking about the intricate details of what exosomes are, what extracellular vesicles are, et cetera, all I heard, I heard a little bit differently, but I could tell that all the other practitioners around me, and there was orthopedic surgeons, there was pain doctors in there, and you could tell that all they heard was peanuts. What's Charlie Brown's teacher? Wah, 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 as they're going through this information, and I could see these doctors getting very frustrated. And there was, the presenter was sharing this awesome information, and I think my next slide actually shows you some of the information they were sharing. But all the doctors wanted to know is, how do we apply this to our particular patient base? What's, if there are any protocols, what are they? How do we use it? What are they going to benefit from? And what they were getting was, what the doctors were getting from this talk was wah, 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 wah. So my job is to take a slide like this, and what I wanted to do is take this slide and turn it from wah, 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 wah into clinical. How does this apply clinically? Okay, so we have the lab bench versus clinical practice. So in this, thank you, whoever just gave me a little love there. So in this presentation, we had the laboratory doctor that was telling us all of this really cool stuff that they see in their product. And this, this is 3 screenshots. I couldn't get one screenshot of all of these growth factors and cytokines that were in this product because there's a ton of them. And so they were trying to go through each individual one of these things. So the doctors are hearing wah, 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 when what they want to hear is clinical practice. How does this apply to clinical practice? So this presentation, I put it together for that company to hopefully bridge that gap between all of this awesome information and this very important stuff. How do we apply it to clinical practice? So that's what it is. Right now, there are a couple keywords that we need to know. So those keywords are this: paracrine action and extracellular vesicles. Paracrine action is very simply a chemical message, the chemical message that is shared between two cells. So you have cell A is going to communicate through a chemical to cell B to tell cell B what to do. That is a paracrine action, and that's what's changing the landscape of regenerative medicine, are these chemicals that are telling these cells that are telling other cells what to do through those chemicals. And they do that through this thing called an extracellular vesicle. If you break that word down, extra means outside of the cell, and it's a vesicle. I didn't even proofread this thing, so vesicles is probably spelled wrong. That's how ready, fire, aim this thing is. So extracellular vesicle is like a vehicle. It's like an envelope of these chemicals that are released for the cell to tell the other cell what to do. So if you take anything away, write those two words down: paracrine action. I guess it's 4 words: paracrine action and extracellular vesicles. And then we're going to take that from this want language down to what does that mean. So first off, let's talk about the FDA, where the FDA is in all of this. Regenerative medicine is still not FDA approved. There are a couple of items that are coming to market that are FDA approved. They do have Medicare codes for them. The problem with them is that those particular products are, frankly, about 15 years behind where we are right now. So things have gotten a lot better in 15 years. But here's where we're at. There's basically 2 pathways for Medicare, for FDA approval and oversight. One of them's the 361, which is where we're at right now. And that basically means that this is a biologic, and the FDA puts it as a 361 and says, hey, we're gonna say that it's safe, and as long as you use it for what they call homologous use, meaning you're not trying to do anything crazy with it. That should say 352. I'm going to change that right now. They want to get it to a 351 where it becomes a drug, and then that way there are clinical uses, there are clinical indications for this particular product. We're just not there yet. The important thing here is that when you work with someone, you work with someone that's on the sunny side of things, not on the shady side of things. You'll look for companies that are doing things like INDs that are looking at this investigational new drug. The old cutoff date used to be November 2020. So next month, the end of next month would have been the cutoff date for these particular companies to get together. And what I found through my years of doing this is all these companies are out competing with each other. And so they're all more than happy to throw each other under the bus. But because of COVID, this November 2020 thing has been shoved forward to, I think, July 21. Don't quote me on that. But my point is, the FDA does have safety precautions in place. We do need to be following those things, but we have not gotten the 351 mark yet. So FDA has not approved the stuff that I'm telling you, but there's mountains of research behind it. So next up, these are in the normal presentation, these would be bullet points that would show up, but my regenerative story goes back to 2018, so about 2.5 years ago. We started doing these injections, and the first person that we injected was my dad, who had 2 knees that were bone on bone. At the time, we used umbilical cord stem cells. We injected it into his knees, and he's done remarkably well, as with most of the patients that we've done these injections for. But these are the 3 main goals of regenerative medicine. Is number 1, we've got to decrease inflammation. You cannot have regeneration until you get rid of inflammation. Inflammation is important. It plays a vital role in this because you have to be inflamed for these injections to work. But We do want to get rid of that inflammation because we can't have regeneration with it still there. Number 2 is we want to modulate and control the immune system. We calm the immune system reaction down in that localized area. Number 3 is regenerate and regrow new cartilage in the joint. That is the ultimate goal. Right now, as it stands, modern medicine really has nothing that they offer as far as a medication or an injection that will actually improve and regrow new joints, or new cartilage, excuse me. That's why we have to go to the regenerative side. And number 4 is to improve the overall health status of the people that we work with. So those are the 4 things, the 4 goals that I wanted to cover in that particular slide. Now, let's talk about the generations. Okay? First generation of biologics or regenerative therapies is PRP, or platelet-rich plasma. And I put this in here, half joking, concentrating growth factors and cytokines since the 1970s. That's just a little my humor, but it has been going on since the early 1970s. Basically, what PRP is you take your own blood, you spin that blood down in a centrifuge, the red blood cells sink to the bottom, the plasma is left up on top. That plasma is full of cytokines and growth factors that are inherently anti-inflammatory. So a lot of people that just do PRP, they see a pain relief reaction right away, which is awesome. They do help with angiogenesis, which is growing a new blood supply. They can help cells proliferate. They help with that paracrine action, that chemotaxis. They can help cells differentiate into new cartilage. They build this scaffolding of collagen and fibrin around the area that is already repaired, but they do offer short-term pain relief. And I kind of compare this to ether starting fluid. These joints that are, let's face it, old and worn out, just like an engine. If an engine's cold and it's worn out, sometimes they struggle to start, and so we got to blast a little ether starting fluid into the carburetor or the air intake, and that ether can really kickstart the engine and get it going. That's exactly what PRP can do for these joints that are worn out. And in some cases with younger patients, the long-term, the older patients will see improvement right in the beginning, but it does tend to wear off. The younger patients can actually see it improve over a long period of time. But I want to be clear, even though this is the first generation, and I call it the first generation, we still use this in every single patient that we inject. Everybody gets PRP because with the exception of the people that we do IVs with, but PRP can give people that short-term pain relief. So without PRP, and if we were to do an exosome injection, I would tell them, expect 4 to 6 weeks until you start to see a difference. But with PRP, it cuts that time down by a lot. So even though, again, it's the first generation of product, we still use it on a daily basis. Next up is using your own stem cells. So early 2000s, 2007 is when it really started to take off. We had the second generation of biologics, which is basically your own or autologous stem cells, where they would harvest this from either your bone marrow or your fat tissue and take your own stem cells and put them back into you, which is awesome. Hey, it does help cartilage to regrow. It does have long-term changes. The problem is that it is age dependent, meaning the more gray hair you have, the longer you get. So when it comes to using autologous or your own stem cells, I'm still a big fan of it, but it's not always the best choice for the older population. A guy my age could do better with it, but it does cost more, and it does require more rehab because it is a little bit more invasive how those are actually harvested. So that is the second generation that moved us into the third generation. I say 2013, and I put it in here as the birth of an industry, tongue in cheek, because this is birthing tissue. So you take perfectly healthy moms and babies born via C-section, and they can donate their birthing material to science. So even here in 2020, I'm still having to say these are not embryonic, these are not aborted fetus tissue cells. There's nothing shady going on here. Everything's above the table, perfectly legal, perfectly healthy individuals that donate this tissue. Then there are labs that can take that tissue and harvest the stem cells from the umbilical cord. You can harvest them from the blood itself, which typically you're not going to get mesenchymal stem cells. You're going to get hematopoietic stem cells, which basically means they're going to grow new blood vessels, which we have seen work in this office. Or you can get them from the connective tissue of the umbilical cord. Then those stem cells, actually, we found those were a little bit better. But it is a cellular product. There is minimal risk of rejection, meaning, and when you see a rejection reaction with these stem cells, it's not like a organ rejection. It's more like, I got the injection, it didn't work. That's, you don't see many negative side effects. It does have long-term effects. It's non-age dependent, but what we used to think is that these cells actually transformed themselves and turned into cartilage, bone, and other tissue. That's the old way of thinking. So again, that's only 7 years ago, right? So if you fast forward today, what we now know is that stem cells have the effect, have that paracrine action, that paracrine effect. Remember we talked about that in the beginning, where they actually act as cell marker, cell signal markers to the other cells to do their job. So here we are, 2020, we're now in the 4th generation of biologics, which basically means we're using these extracellular vesicles. Remember I told you that word's important. There are these pouches or these envelopes of chemicals that are released by the stem cells to go to the dead and injured cells to tell those dead and injured cells what to do. Also known is, Dennis, thank you for asking a question. I appreciate that. I will get to that shortly, bud. Short answer is yes, but I'm not promising you anything. I've seen some studies about, well, we'll just answer it now. In a second here, when we're talking about the clinical applications, most of the people that we inject right into the joint. There are some people that do really well by doing IVs. So you do these exosomes via IV therapy. We know exosomes are small enough to cross the blood-brain barrier, and they can help with things like depression, anxiety, schizophrenia. There has been some work done on that, but if you were to do that in my office, Dennis, you basically would be signing a piece of paper saying, we're just doing this for your overall general health, and I'm not promising anything. However, I haven't seen it clinically, but I've seen papers about that very topic, so I appreciate you asking that, bud. So back to the 4th generation of biologics, so we're talking about stem cell exosomes. Basically what we're now dealing with is no longer a cell. There's no DNA involved. It's just these vesicles or these pouches. Did I throw a picture of it in here? Yes, I did. It's these pouches that the stem cells release. So the cell itself is formed, has this layer over it called the phospholipid bilayer, which is basically a layer of fat that surround the cell. You're welcome, Dennis. I appreciate you asking questions, bud. These stem cells release these exosomes, which those exosomes themselves have a phospholipid bilayer around them, but they're full of these chemical communicators, right? They're full of mRNA, they're full of microRNA, they're full of growth factors, they're full of cytokines. So basically what they do is those little vesicles will cross from the good stem cell, and the stem cell releases like thousands of these things. So they'll cross and go to the cell that needs help, and they're a chemical signal to tell that cell what to do, okay? Again, these are non-cellular. They're about 1/1000th the size of an actual stem cell. And if you're talking about one exosome with thousands of these mRNA particles in there, one mRNA particle can be responsible for up to 1,000 proteins. Okay, so if you think about collagen and tissue repair and things regenerating, one of those mRNAs can tell those chondrocytes, which are very specific cells inside of your joints that produce cartilage, then they can help produce about 1,000 of those each. Okay, so if you've got millions of mRNA particles and each million can stimulate the growth of 1,000 proteins, then we're talking about thousands of, my brain can't even comprehend that number. basically what we've done in the last, I'm not taking any credit for this, we just use it clinically, and now I'm giving all the credit to the lab guys. They've made stem cell therapy much safer. They've made it much more powerful, so it's concentrated, and it's, I can't say enough good things about it. Go to my webpage for more testimonials. So here's the clinical applications. Okay, this is what people wanted to hear at that seminar that I attended. How do I use this in my practice? So here it is. Number one, if it's an osteoarthritic knee, we take 1 cc of these exosomes, we combine it with your own PRP, and we inject it directly into that knee. The same is said for the shoulder. Take 1 cc, add PRP, inject it into the knee. Okay, the spine, whether you're talking about the cervical spine, the thoracic spine, or the lumbar spine, we take 1 cc per level and PRP. So we take PRP with everybody. We inject it into the paraspinals at each level. So it goes into the muscle, doesn't go into the spine itself, into the muscle. By the way, you see DC at the end of my name. I am a chiropractor. I'm not the one who does the injections. We have a medical staff for that. I've had the most experience with these, so I'm the one who teaches it. Okay. So they go into each paraspinal on each side of the actual injury. The key word in those, when I go through patients' imaging, is facet arthropathy. What I mean by that is arthritis in the facet joints respond really, really well to this. For the hip, 1 to 3 cc's, depending on the patient, better outcomes with guided injection if you can get them into the joint capsule. We don't have the ability to do that yet, but we're getting good results by putting it into the SI joint and into the trochanter over on the femur. That's how we do hips. And then literally everything else, Dennis, this goes back to what you asked me. Everything else we consider overall general health, and we'll do with 5 cc's most commonly. If you're bigger, then you may require more. Bigger being 250 pounds or more, then we may want to talk about doing more than 5 cc's. But financial tolerance is an issue, right? Conversation I have every day is, if you can't afford it, don't do it. Because if you spend all your money doing this, your stress levels go up. And then if your stress levels up, your chances of us helping you are much, much less. So next thing is the clinical mechanism, right? So again, remember that I wrote this for clinicians that want to use this in their office, but this is the mechanism. The inflammation that you have that's causing you pain is acting as a paracrine signal. It's a call out to those cells, for the cell saying, hey, I'm injured, I'm the one that's hurt here, so I'm going to release this inflammation so you know that I'm the one that's injured. So it's very, very important when we do these injections for patients to be off their anti-inflammatories 3 days before we actually do the injection. Number 2, PRP is injected with exosomes acting as short-term anti-inflammatory. 5% of cases will get off the table feeling better, and the scaffolding begins to form. Glucosamine, chondroitin, protein, fat, and hydration are key as far as the nutrition side of things, because we want to give the body what it needs to actually regenerate. And then that matrix scaffold begins to form. And then the exosomes, they signal the chondrocytes. Those are very specific cells in your joint to form new cartilage as little as a week, with the biggest changes seen in 6 to 8 weeks. And then hopefully the outcome is that surgery is delayed or avoided altogether. Imaging, it's important to manage patients' expectations. Imaging is probably not going to change. To truly measure how much cartilage is in the tissue takes very, very expensive MRI imaging that's usually only available at big hospital systems. We just don't have this here in little Idaho Falls. I'm sure the University of Utah does, but you could probably see a difference there. But just going over here to the local hospital doing an MRI, you're not going to see any big changes or anything there. As far as other therapies that you could do, low laser therapy is something we do with every patient. On injection day, we'll actually use laser over the site where we injected it, and then follow up with more laser and shockwave to help those stem cells continue to proliferate. I need to put in here custom orthotic production. We want to make sure we're dealing with any of oops, let's capitalize those. If there's any biomechanical issues having to do with everything but the shoulder, then typically orthotic production is actually very helpful in those particular cases. And so that's how we do it with follow-up, is we will use these particular devices to help get better results, both short-term and long-term. That's the presentation that I put together. I'm going to polish this thing up and make an actual official video. I appreciate your questions. I appreciate your love. If this is something that you want to chat about, then reach out to us. We'd be more than happy to get on the phone with you and talk more, answer your specific questions. You guys have been great. Dennis, thank you for chiming in again. Any other questions, feel free to ask them. I'll watch this video over the next couple days, and if I can answer, I will. So thanks a lot, guys, and we'll see you on the next video. Thanks.